Hello and welcome back to The Unlicensed Therapist. I'm your host, Matthew Grimm. And before we get into today's topic, I want to answer a question that has been asked, just to be transparent. I have had several people ask, why only 13 episodes in season 1? Why didn't you keep going? What was the thought process there? And in truth, when the idea of the unlicensed therapist came into my mind, I sat down and I penned out 13 scripts. And that was the original idea, that if I can get through 13 of these episodes, then I will have met my goal, and where it goes from there, who knows? And along the way, different people would mention to me other ideas that they thought would be beneficial or that would be great following up on another topic, and I would find myself sitting down, writing up another script and putting that in place of what was supposed to be the next show. So, for example, today's episode in my outline is episode 11, and here it's falling into episode 15. So that can show you how I ended up with extra episodes and meeting goals, and I just decided that I was going to take the same approach that I would with a client, that instead of the unlicensed therapist being this huge, monumental, unachievable goal, that I would break it down into bite sizes. And as long as I got so far, and in this case 13 episodes, then I would have met my goal. So, now that I have explained that, let's talk about where we're stepping into today. And that is community mental health, or what we'll call CMH for the remainder of the episode. CMH is a world all of its own that shapes the careers of thousands of new clinicians and probably around the lives of 5 million or more clients. If you're currently in grad school, you just graduated, or you're a clinician who's trying to find your footing because you don't have a license yet, chances are your options for employment are community mental health, and community mental health. Or someone has told you you'll probably start in community mental health. Have you ever wondered why that is, or what it really means? What is community mental health? Well, that's what today's episode is for. Community mental health is the backbone of the mental health system in the United States. It's where the most vulnerable clients receive care, and where many clinicians learn the craft under pressure, in the trenches with limited resources and enormous need. Today we're going to pull back the curtain on what CMH actually is, how it came into being, the good, the bad, the ugly, and the beautiful of CMH, the pros and cons for clients, the pros and cons for clinicians, and how to survive for some, and for others, how to thrive in CMH. This is one of the most important episodes in the entire series, so let's get to it. Community mental health, or CMH, is not one thing. It's a network, a system, a safety net, a patchwork of services designed to make mental health care accessible to people who otherwise would never have it. When we say CMH, we're talking about outpatient therapy, psychiatry and medication management, case management, crisis intervention, school-based services, residential programs, assertive community treatment teams, mobile crisis units, peer support, wraparound services, and so much more. But at its core, CMH is built on a simple belief. Mental health care is a human right, not a luxury, not something reserved for people with great insurances, not something you only get if you can pay $150 a session. And yes, it would be great if every person we saw, we could bill $150 per session and put that in our pocket, but it's not a reality, especially in this economy. And that's why CMH exists, because people can't afford that, but they deserve care even when they're uninsured, underinsured, homeless, struggling with addiction, living with severe mental illness, or navigating systems that were never designed with them in mind. It's the front line, the safety net. It's the place where the work is hardest and often the most meaningful. To understand CMH today, we have to go back to the mid-20th century. For decades, mental health care in the United States was dominated by large psychiatric institutions. These institutions were overcrowded, underfunded, and often abusive. Go back and look up on YouTube Pennhurst for information on news stories that was done on that institution. If you do so, a warning that there are some trauma triggers involved, and you better have a Kleenex box next to you ready to dab those tears. In these institutions, people were warehoused, not treated. Investigative journalists exposed horrific conditions, and families demanded change. At the same time, new psychiatric medicines were emerging, medications that made it possible for some individuals to live outside institutions. And then came a major shift: deinstitutionalization. Now, when you hear that, what comes to mind, or what many in the general population think of, is that these institutions were closed down and every person in the institution was thrown out into the streets in order to fend for themselves. And while that did happen to some, I'm not going to lie and sugarcoat it. Really, the plan was for people to leave the institution who the institution felt was able to leave and move into communities where they could receive care while living more independent lives. And that sounds beautiful. The reality was, you took someone who was living in an institution. Possibly they have no memory other than living in that institution with 1, 2, 3, or 10,000 people. You pick them up, you place them in a house with 1 other, 2 other, 3 other people. You use the same methods as you did in the institution, in that house, and you never ask them, do you want to leave the institution? Is this where you want to live? Are these the people you want to live with? Would you like a job? What would you like to do with your life? These basic questions didn't get asked, but over time, this system evolved into something because it was based on hope. In 1963, President John F. Kennedy signed the Community Mental Health Act, which promised a nationwide network of community mental health centers. It was a beautiful vision that there was no funding for. So as these institutions closed, and really what we should say is they shrunk their populations so that only those who truly needed to be there remained, or some of them did close totally, and those people were either moved to other locations, other institutions, or they ended up out in the community in some way or form. But as these institutions closed, and community centers meant to replace them were never fully funded or fully built, the responsibility for caring for people with severe mental health illnesses shifted, not to a well-resourced community center, not to group homes who had the most recent trainings. It was shifted to underfunded community mental health agencies, emergency rooms, homeless shelters, group homes, jails, and families who had no support. This is the true origin of community mental health. A beautiful idea, underfunded from the start, trying to do the work of two systems with half the resources. And yet, it remains essential even today. Let's talk about the hard parts, because community mental health, it's not easy. Not for the clients and not for the clinicians either. In community mental health, your success is often measured by productivity, and that is the percentage of your paid time that you spend directly billing for services. So what does that mean? That means high caseloads, back-to-back sessions, limited time for documentation, limited time for consultation, limited time for breathing. So I'll give you two examples from my lifetime. At one agency, I had a caseload of around 100 to 120 people on my caseload, expected to see as many of them as possible in a bi-weekly period. While I had control over my schedule, it was hour-long sessions. You often would get double booked if you had someone who was a no-call, no-show, so that you could attempt to make sure someone was seen, and if both persons showed up, then each got a 30-minute session. Sometimes there was even triple booking. Documentation was either done in session with the client, and there were some clients that thought this was the best thing in the whole world, and others that that's not what they were there for, so you were either doing it during a no-show or at the end of the day. There was time set aside for consultation, but if you needed something, then you had to see when you had availability and the supervisor had availability to have that conversation. And sometimes that was an impossibility. Then there were the simple things, taking a breath, going to the bathroom, having lunch. These were things that you learn to schedule and block out so that you didn't get just bombarded. My other experience had about 80 to 100 people on the caseload. You were scheduled for 45-minute sessions, back to back to back to back to back, with a lunch break scheduled in. Your productivity was counted daily. You were expected to meet a certain productivity each day and each week and keep track of that so that by the end of the month you met your productivity. And if you had no call, no shows, then during that time you should be following up, calling in other people. You should have a backup system. People should be walking in the door and receiving therapy non-stop. So that meant in both of those situations and in other situations, you might be paid 40 hours a week, but you could be expected to bill anywhere from 26 of those hours to every single hour that you're being paid for. And that means you're squeezing in documentation, crisis calls, contact calls, and supervision into the margins. And that's the ugly part. Productivity pressure can lead to burnout, ethical drift, and emotional exhaustion. Now, having said that, I want to be upfront and say that in my experience, the direct supervisors of the department, those who were trained as therapists, knew what this was putting onto your shoulders, knew that there are things that we're trained into and not to do in our grad school programs, knew the importance that if we're not healthy, our clients aren't healthy, and would do the best to provide shelter, but still had to abide by certain regulations because of their own position. It was more often people far above those supervisors who were in the financial aspects of running a company, who had no training as a therapist, who were making policy decisions on how someone should have a schedule, see people, and what a successful session may look like or not look like, all due to or based off of is someone coming in consistently or not. CMH clients often face a lot of barriers themselves, and typically I found that the number one barrier was a tie of either housing instability or transportation barriers. I have nowhere to live, or I have no way to get to you. And this was very quickly followed up by employment issues and food insecurity. If I can't work or I don't have work, then I don't have the money to get housing, to pay for transportation, to get food. Now, the cause of this was typically co-occurring disorders, and this could be anything from multiple mental health disorders to substance disorders and other mental health disorders. traumatic histories, chronic medical issues, and legal involvement. Oftentimes, individuals that you are seeing in community mental health are not coming in because they want to be there. They're being told they must be there from a legal aspect, from a housing center, a homeless shelter that's saying you must meet these certain check marks to maintain your space here. And so these folks know that I have to come, do an intake, and show that I am in therapy. But if I do not want to be here, what happens? I don't show up. And after not showing up so many times, what happens? A letter gets sent out for re-engagement. And just as you're ready to discharge that person, they walk in the door at the last moment. And this seems to become a recurring cycle. Now, we can look at this from two very different viewpoints. One is the judgmental viewpoint. This person is being manipulative, and they know how to work the system, and shame on them. They are taking up valuable real estate on my calendar, and taking away time from other people. We can also look at it, though, from a viewpoint of, I don't want to be here. I need to survive. And where I'm at says that to survive, I need to show that I'm in therapy. But it's more important to me to find a job so that I can become self-sufficient, to find transportation, to find a food source. So, while therapy is a nice thing and you are a great person, that time with you is time that I can be doing those other things. So once I get that letter of, oh, you're going to close me out, I come back and I do a few sessions because I do see that it's helpful, but then other things come up in my life. Or, yes, the parole officer or probation officer says, I have to be here. But I want to get back into my regular life. Or I'm still making some poor choices. My health is so poor that it is making it so that I can't even get out of bed. Or I'm in the hospital. I can't be treated because of where I'm living, or my medical status, or other things. If I'm sleeping in my car, anxiety should be expected. Depression should be expected if I've got no food. This is a way that my body is telling me that I need to do things to save myself. You cannot treat trauma when your client is in consistent crisis. And this is where you become not only a therapist, but a case manager, an advocate, a resource navigator, a crisis responder, and you do it all with limited time and limited resources. As you're going through that session, you switch from the therapist and you hear a comment about needing a resource, and you instantly put on that case manager hat, and that person doesn't need a therapeutic skill to take out of the room. Now they need a resource to take out of the room. So you're going through and looking through the resources with them and offering those resources. Or that person has contacted those resources and got nowhere. Now you're contacting that location with them in the room on their behalf, because so often an agency contacting an agency will get more forward movement than an individual contacting the agency. You're planning your crisis plan for possible things that could happen in the upcoming week that your client is telling you could set them off, could put them out of recovery. You're working with them to stay stable. Another huge challenge is staff turnover and just the instability of the organization overall. Community mental health agencies often struggle with high turnover because of low pay, leadership changes, inconsistent policies, and just being understaffed. One of the locations I worked at during the pandemic was run by 4 therapists, 2 were supervisors, and anyone else other than the other 2 therapists who weren't supervisors were interns. And that place ran for the entire pandemic basically on interns. That type of instability affects everyone, especially the clients. This is where the client is walking in the door and wanting to know, are you an intern? Are you going to be here forever? Because I know that every 3 to 6 months, there's the possibility that an intern is going to graduate, is going to get their hours, and may not be here. You carry stories that stay with you. You witness suffering that is systemic, not individual. You care deeply, and sometimes too deeply. This is the emotional tax of CMH. Let's focus in on the good and the bad of CMH. So the good for clients when it comes to CMH is that it offers some very critical things. Accessibility, low or no cost services, multiple services that wrap around to provide support, crisis intervention, multidisciplinary teams, and cultural and community connections. For many clients, the idea of community mental health is not just a service, it's their lifeline. Now, the bad. Clients also face long wait lists. Sometimes they can get onto your schedule and have a session, and you go to schedule that next session, and in that plan, you're supposed to see them weekly or bi-weekly, but you're scheduled out so far that you may not be able to see them for another month. There's a lot of staff turnover. People get burnt out. Interns come in, get the experience they need, and they move on. Some people just come in, see what community mental health is, and it scares them, so they leave. As I've already mentioned, there's limited session frequency. Your clinicians are overworked. There are systemic barriers that sometimes just can't be overcome, and there's inconsistent follow-up. Clients deserve more than the system can always provide. Now let's talk about the part that often gets overlooked. CMH is one of the best training grounds you will ever have. You are literally going to experience every single diagnosis out there on top of the kitchen sink being thrown at you. You're going to experience various populations so that you can not only decide in your mind what works for you and what doesn't work for you, but through experience. You will get to work with children, teens, adults, seniors. You will get to work with people who have just minor anxiety, someone who has a borderline personality disorder, someone on the autism spectrum, and everything in between. You may deal with individuals with suicidal ideations or homicidal ideations. These are things that are going to hone your skills. You're going to grow, and you're going to grow very fast. That diverse, complex populations and cases, you're going to learn how to crisis manage and how to case manage. You're going to learn to be flexible, but you're also going to learn humility. You're going to realize that someone who comes in and just complains and blows off steam is coming in and doing that in your office because it's a safe place to do it, and if they did it in their normal life, there would be consequences that would affect them for the rest of their life. You're going to learn how to build alliances under pressure. You're going to learn what it's like to collaborate with multidisciplinary teams, which is a good and a bad, because you're going to learn how teams can function together and how bringing different teams in to work with the same person, they all have different rules for their playground that every team has to abide by, each of their own rules, and that can be problematic. The beautiful. There is beauty in CMH that you cannot find anywhere else. The client who shows up after missing 5 sessions, not because they're afraid of being discharged, but because they trust you. They didn't come in because there was something that they saw as a failure, and they had to work through that to be able to look you in the eyes and tell you what happened. The teenager who finally feels safe enough to cry. The parent that gets housing after months of advocacy work. The client who says that you're the first person who ever listened to them. The small wins that feel like miracles. CMH teaches you that healing is not always dramatic. Sometimes it's a warm meal. Sometimes it's a bus pass. Sometimes it's a safe space for 50 minutes. This is the beauty of CMH. You witness resilience every single day. Now, CMH is often a launchpad, not a life sentence. It gives you training, experience, which grows into marketability. You grow in your clinical confidence. You get supervision. It could be licensure, it could be supervisory, it could be administrative, it could be all three. When you're interviewing for a CMH, remember to ask these questions. What are your productivity expectations? Get them to explain them in plain language that you will understand. Both places I worked for used units, and they both calculated units as different things. So it's important that if someone is using language that isn't hours or minutes, that you drill down and ask so you get specifics. Is supervision provided? Is the person providing the supervision licensed? Would it work for you towards licensure? How often could you get supervision? If you do take that, is there a contract you have to sign? If there's a contract, do you have to stay extra months or years once you're licensed? And are you willing to do that? What's the staff turnover rate? Any place that says they have a very low staff turnover rate, or that they don't have clients that don't show up, are lying. How many clients are on a typical caseload? What does the agency's support of clinicians' well-being look like? A healthy community mental health agency exists, but you have to know what to look for, not only for the agency, but for you. Community mental health is challenging, essential, exhausting, inspiring, frustrating, and profoundly meaningful. It is good, it is the bad, the ugly, and the beautiful. I know one area of contention is pay and the amount of productivity put on to clinicians. And are clinicians underpaid? Yes. However, there's often something we don't think about. There are a number of individuals working in community mental health that are support staff. They are unable to bill for a service. The people who are able to bill for a service are those who are bringing in money for the agency. Those are the people that are paying the salaries, the rent, and the other bills so that the agency can keep moving forward. So that means even if you would calculate that the agency could afford to pay you $150 an hour, that means the front desk people go, IT goes, and so does fiscal, and you'd have to be doing all of that plus what you were doing. Trust me, none of us want to be doing all of that, especially in a community mental health system. If community mental health is part of your journey, honor the work, but protect your boundaries. Respect the system, but don't lose yourself in it. Serve your clients, but remember you are human too. In the coming weeks, we're going to continue our series on pulling back the curtain on different types of therapy, including group practices and private practices. I'm looking to bring in someone from community mental health to talk with, as well as someone who is a group practice owner and owned a private practice, so that we can get some viewpoints from people who are actually in the trenches. If today's episode resonated with you, subscribe to The Unlicensed Therapist. Share this episode with a student or a new clinician. And remember, we'll always be unlicensed as long as we're still learning. Thank you for being here. Thank you for doing this work. And I'll talk to you next week.